Assalamu alaikum. Hello everyone. Today we are going to discuss anatomy upper limb, first lecture of our course. We will start by discussing bones of the upper limb. We have the three most important bones of the upper limb: clavicle, scapula, and humerus. Regarding clavicle, this is the clavicle. As you see, we have here medial 2/3 and lateral 1/3. This medial 2/3 is convex forward, while lateral 1/3 is concave. Here is the junction between the medial 2/3 and the lateral 1/3. The most important here that clavicle has a sternal end and acromial end. Sternal end is flat and straight, while the acromial end is slightly curved. Here, in the lateral part of the clavicle, we form the acromioclavicular joint. Acromioclavicular joint. When the medial part of the clavicle is with the manubrium and sometimes with the first rib. Please keep this. All information you should know about clavicle is that medial 2/3 is convex forward, while the lateral 1/3 is concave. Here is the junction between the medial 2/3 and the lateral 1/3. We have a sternal end and acromial end. Sternal end, which is flat and straight, which can articulate with the manubrium and the first rib. And the lateral part, which is the acromial end, forms the acromioclavicular joint. We have a very important landmark in the clavicle here, which is the conoid, tubercle, and the trapezoid line. They are on the inferior surface. They are on the inferior surface of the clavicle. Conoid, tubercle, and trapezoid line. They play an important role in attachment of the coracoclavicular ligament. Coracoclavicular ligament. While regarding the sternal end, at attachment with the costoclavicular ligament. This is very important. Then, here is the acromial end, which is flat, and the sternal end. The acromial end has a facet for articulation with the acromion of the scapula, and we have the sternal end, which is a straight and articulate with the manubrium and the first costal cartilage. We have two important landmarks on the inferior surface, which is the conoid, tubercle, and the trapezoid line for attachment of the coracoclavicular ligament. This is all what you know about the clavicle. Here is the second bone of the upper limb, which is the scapula. Scapula, here, I will share this picture. Here is the scapula, and what's more important in this scapula is, here is a very important anatomical landmark, which is called the spine of the scapula. The spine ends by what's called acromion, and acromion is found on the posterior surface of the scapula, while on the anterior surface of the scapula is the coracoid process. We have two processes important in the scapula: coracoid, anterior, and acromion is posterior. Remember that A is not anterior. A is not with A. So acromion is not anterior. Acromion is posterior. So coracoid is anterior and the acromion is posterior. Acromion is the end of the spine. Another important landmarks are the supraspinous fossa and infraspinous fossa. This is the origin of supraspinatus muscle, and this is the origin of the infraspinatus muscle. They are muscles called rotator cuff muscles, which form the word sits. What is this word sits? They are the supraspinatus, infraspinatus, teres minor, and the subscapularis muscle. Supraspinatus, infraspinatus, teres minor, and subscapularis muscle. These are the most important. Here, you should know also what's called the suprascapular notch. Here, the suprascapular notch. This is a notch which is found over the upper border of the scapula for passage of the suprascapular nerve and vessels. Anyone know from where the suprascapular vessels arise? Okay. I'll wait. Anyone knows that? Suprascapular vessels from where? Okay, suprascapular vessels arise from thyrocervical trunk, first part subclavian. First part subclavian artery will give you the thyrocervical trunk, which gives the transverse cervical and the suprascapular arteries. Okay, this is the first part subclavian. Okay, let's continue. We have here what's important: the spine ends by acromion. We have supraspinous fossa and the infraspinous fossa for origin of supraspinatus and the infraspinatus muscle. What's important here also is the suprascapular notch for passage of suprascapular vessels and suprascapular nerve. Suprascapular vessels arise from the thyrocervical trunk, first part subclavian. We have also, this is the posterior surface. And what about the anterior surface of the scapula? Here is the anterior surface of the scapula, or what's called the costal surface of the scapula. A great fossa, which is called the scapular fossa, for origin of the subscapularis muscle. Okay, it is one also of the rotator cuff muscles. I said before, they form the word sets: supraspinatus, infraspinatus, teres minor, and subscapularis muscle. You have here the upper border, and this is the medial side, and this is the lateral side. Here is the inferior angle. I said this is the anterior. So A is not A. Anterior is not acromion. Anterior is the coracoid. And the posterior is the acromion. Here, a very important landmark, which is called the glenoid cavity. Glenoid cavity is the site of articulation with the head of the humerus. It is a type of joint which is called synovial joint with pole and socket variety. This is a synovial joint with pole and socket variety. Please keep this. Here is the glenoid cavity. This glenoid cavity has a fibrocartilaginous rim surrounding it, which is called the labrum glenoidal. Labrum glenoidal play an important role in just maintaining the stability of the shoulder joint. What is the most important stabilizers of the shoulder joint? They are the rotator cuff muscles. Rotator cuff muscles. Okay, and here we have superior supraspinous fossa for the supraspinatus muscle, and the inferior is the infraspinatus fossa for infraspinatus muscle. And the posterior surface, which has the subscapular fossa for the subscapularis muscle, and the superior part, which has the coracoid process, I say it's the coracoid process, is the most anterior, okay, is the most anterior. And also we have the suprascapular notch for passage of the suprascapular nerve and vessels. This is all regarding the scapula. Please, scapula is very important. Keep all this. Okay, another one regarding the third bone of the upper limb, which is the proximal humerus. Here is the proximal humerus. Proximal humerus, this is the head, which articulate with the glenoid cavity to form the shoulder joint or glenohumeral joint. Glenohumeral joint. Okay, so we will start by, this is the head, and what's below it directly is the anatomical neck. And we have here the most lateral is the greater tubercle, and posteromedial is the lesser tubercle. We have the greater tubercle and we have the lesser tubercle. Between the greater and the lesser tubercle, we have what's called the intertubercular sulcus. Intertubercular sulcus. What's the structure which passes in the intertubercular sulcus? Above is the long head of biceps, and this greater tuberosity continue downward to form the lateral lip of bicipital groove, while the lesser tuberosity continue downward to form the medial lip of bicipital groove. And here I have the lateral lip and medial lip and floor in between. Lateral lip for pectoralis major, medial lip for teres major, and the floor for LD, latissimus dorsi muscle. So I have major, and between them is the latissimus dorsi muscle. The major in the lateral part is the insertion of pectoralis major muscle, while in the medial part is the insertion of teres major muscle. In between, floor of the intertubercular sulcus or the bicipital groove is for insertion of latissimus dorsi muscle, while between the two tubercles above is for passage of long head of biceps. I have here a very important information. Whereas the glenoid cavity has a supraglenoid tubercle and infraglenoid tubercle. Supraglenoid tubercle for long head of biceps, while infraglenoid tubercle for long head of triceps. Please keep all what I say. Again, this is the proximal part of the humerus. I have head which articulate with the glenoid cavity to form the shoulder joint or glenohumeral joint. This is a synovial joint of pole and socket variety. Then I have the greater tubercle and the lesser tubercle. In between them is the intertubercular sulcus for passage of long head of biceps to be inserted into the supraglenoid tubercle. Then I have the greater tuberosity to continue downward to form the lateral lip of bicipital groove, while the lesser forms the medial lip of bicipital groove. In between them, I have the floor for latissimus dorsi, lateral lip for pectoralis major, medial lip for teres major. So I have two major, and in between them is the latissimus dorsi muscle. Then, regarding the shaft, I will erase all that. I have a slightly good information about the shaft, which is here. I have in the lateral part of the shaft what's called the deltoid tuberosity, a rough area over the lateral part of the mid shaft of the humerus for insertion of the deltoid muscle. Opposite it on the medial side is the insertion of the coracobrachialis muscle. Please keep this. On the lateral side, deltoid tuberosity. On the medial side, opposite it is the insertion of coracobrachialis muscle. Here, what is the most important feature regarding the greater and lesser tuberosities of the humerus? The most important is that the greater tuberosity is the insertion of the rotator cuff muscles, which I said before, they form the word sit. SIT in the greater tubercle, while the S is in the lesser tubercle. So I have supraspinatus, infraspinatus, teres minor, and in the lesser is the subscapularis. Here is the insertion of the rotator cuff muscle. Please keep this. In the greater tubercle, I have the supraspinatus in the upper part, infraspinatus in the middle part, teres minor in the lower part, all of them in the greater tubercle. While in the lesser tubercle is the insertion of the subscapularis muscle. This is all what you need about the proximal humerus. Another one. Regarding what I said before, this is the glenohumeral joint. Glenohumeral joint, this is the glenoid cavity I have here. This is the glenoid cavity surrounded by fibrocartilaginous limb, which is called labrum glenoidal. Labrum glenoidal. This is one of the stabilizers of the shoulder joint. Pole and socket variety, synovial joint. This is important regarding it. What are the movement of the shoulder joint? We have flexion, extension, adduction, abduction, internal and external rotation, and circumduction. Circumduction is the movement of the shoulder joint. Then we have the distal part of the humerus. This is a very important landmark, the distal part of the humerus. Here is the medial and here is the lateral. You should remember that MTCL. MTCL from medial to lateral. I have this medial epicondyle, I have trochlea, capitulum, and lateral epicondyle. Medial epicondyle, trochlea, capitulum, and lateral epicondyle. This is the ventral surface of lower humerus. Lower humerus from the front, I will start medially, medial epicondyle, then trochlea, capitulum, lateral epicondyle. What's above this trochlea? This is a fossa which is called coronoid fossa. And here, what's above the capitulum is the radial fossa. Radial fossa for head of the radius. Coronoid fossa, coronoid process of the ulna. This is important. Which articulate with the trochlea is ulna, because ulna is medial, regarding the medial epicondyle. Which articulate with the capitulum is the head of radius. You should remember that a very important ligament surrounding the neck of radius is called the annular ligament. Annular ligament, which starts from the ulna, surround the neck of the humerus and backward to the ulna, is called annular ligament. Annular ligament is responsible for supination and pronation of superior radioulnar joint. Supination and the pronation process of superior radioulnar joint. Please keep this: medial epicondyle, trochlea, capitulum, and the lateral epicondyle. Above the trochlea, I have the coronoid fossa. Above the capitulum is the radial fossa. Okay. Then we will go for the radius. Most important regarding radius, I will share now. Here is the radius. We have here head of radius, which articulates with the capitulum. I say it medial epicondyle, trochlea, capitulum, and the lateral epicondyle. So this articulate with the capitulum. Then I have below it the neck, constriction called the neck, related to the annular ligament. Then what's called the radial tuberosity. What's the importance of the radial tuberosity here? It is the insertion of the biceps brachii muscle. Where is the insertion of the biceps muscle? It is on the radial tuberosity. Then from the shaft, I have an oblique line passing downwards. Okay, then the most important landmark here is that I have triangular lower part of the radius, which is a broad lower part of the radius. When you see the lower part of the ulna, it is narrow and have a slight small styloid process, while in the radius, it is a large triangular lower part and have a radial styloid process. Okay, also there is an important landmark. When you see that, it's called the dorsal tuberculoflister. Here is the dorsal tuberculoflister. For passage of extensor pollicis longus tendon. This is an important landmark which came in the previous questions. What is the importance of dorsal tuberculoflister? It is for passage of the extensor pollicis longus tendon on the dorsal aspect of the distal radius. This is also a very important landmark. This is all what you know about radius. We have head, neck, radial tuberosity for insertion of biceps, then oblique line anterior, then the lower part, which is triangular and broad, and have a radial styloid process. On the dorsal aspect of it, we see the dorsal tuberculoflister for extensor pollicis longus tendon. This is all what you know about it. Let's go for carpal bones. Carpal bone. What is the number of carpal bones? There are 8 bones. We will count them. Here is the lateral, and here is the medial, and here is the proximal row, and here is the distal row. Okay, then we will start from lateral to medial. We will count scaphoid, leonate, triquetrum, and pisiform. And please keep a very important information regarding pisiform. I will say at the end. Then this is the proximal row. I will say again: scaphoid, leonate, triquetrum, pisiform. Then the distal row is the trapezium, trapezoid, capitate, hamate. Trapezium, trapezoid, capitate, hamate. What is the largest carpal bone? The largest carpal bone is the capitate. Please keep this information. The largest carpal bone, the first bone to ossify is capitate. The largest carpal bone and the most important bone to ossify is the capitate. It is here. It is in direct contact with the third metacarpal bone, third metacarpal. While hamate has a relation with 4 and 5th metacarpal bones. This is a question also came in the exam. Okay, regarding capitate, the largest carpal bone and the first bone to ossify and has a relation to the third metacarpal, while the hamate in relation with the 4th and 5th metacarpal. This is a very important information regarding carpal bone. Please keep all of them: scaphoid, leonate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. A very important information regarding the pisiform is playing an important role in the insertion of tendon of flexor carpi ulnaris. Flexor carpi ulnaris insertion here in the sesamoid bone, which is called the pisiform. Then it sends pisohamate and pisometacarpal ligaments. This is a sesamoid bone. What is the function of the sesamoid bone? Play an important role in transition of movement and minimize friction. Transition of movement and minimize friction between the tendon and the other bones. Insertion of flexor carpi ulnaris in the sesamoid bone called pisiform. Then from pisiform, we send pisometacarpal and pisohamate ligaments. Please keep all of this. This is regarding all bones of the upper limb. We discussed clavicle, scapula, humerus, radius, and carpal bones. Okay. We will go. What's important here is the scaphoid bone fracture. Scaphoid bone fracture, which is the most important bone fracture in the carpal bones. We have 2 bones undergo a vascular necrosis: scaphoid bone and leonate bone. Scaphoid and leonate. 2 are exposed to a vascular necrosis. Scaphoid bone, we have the bone which has a waist, proximal end, and distal end. Blood supply comes from the distal end through dorsal metacarpal and the dorsal intercarpal vessels from urinary artery. When there is a fracture of the waist, so distal part takes a blood supply, while the proximal part does not take any blood supply. So a vascular necrosis is on the proximal part of the scaphoid. Very important, when the patient is exposed to fall on outstretched hand and has tenderness over the anatomical snuff box, this is a scaphoid bone fracture. What will you do with a scaphoid bone fracture? Initially, you will do an X-ray. X-ray. So X-ray, if the X-ray here didn't give you any data, then within the first 24 hours, you will do CT. After 24 hours, you can do 2 of both, either bone scan or MRI. Please keep this. Initially, I will do X-ray. And in a large amount of patients, nothing will appear in the X-ray. So I will do, within the first 24 hours, I will do CT scaphoid. If after the 24 hours, I can do bone scan or MRI. Bone scan is in the first 72 hours, while MRI in the first 2 weeks. Then after 2 weeks, I can repeat the X-ray. So please keep this regarding investigation of the scaphoid bone fracture. X-ray, CT, bone scan, MRI, and X-ray can be repeated after 2 weeks. What will you do? I will put the hand in the thumb spica. Thumb spica immobilization of this thumb, because the scaphoid is in the base of the first metacarpal. Okay, so we will keep it here. Another bone which is important to know, undergo a vascular necrosis during a trauma and falling on outstretched hand, it is the leonate bone. Leonate bone. What is the fracture of leonate bone which undergo a vascular necrosis? It is called the Cane-Bock fracture. Cane-Bock fracture. This is a vascular necrosis of the leonate. It's called Cane-Bock fracture. Okay, keep scaphoid and leonate fractures. Another one. We have here what's called the carpal tunnel. A very important question asked. It is called the carpal tunnel. We have this photo. What form is the carpal tunnel? Here I have initially the flexor retinaculum, which passes all over the wrist, which can start laterally. I have here, this is the lateral part, and this is the medial part, which can start laterally from the scaphoid to pisiform, then trapezium to hook of hamate. The lateral of flexor digitorum profundus. Also here I have tendon of flexor pollicis longus with a separate synovial sheath for it. So here is a 9 tendons, and the most important nerve to be compressed here and the most superficial in this tunnel is the median nerve. Please keep the most superficial, the most important in this carpal tunnel is the median nerve. Then we have 4 tendons of flexor digitorum superficialis, 4 tendons of flexor digitorum profundus, and flexor pollicis longus. And in a separate tunnel, which is found within the flexor retinaculum, is for flexor carpi radialis tendon, flexor carpi radialis. And here, the most important also to know what's called the anatomical snuff box. Here is the anatomical snuff box. Here, like that. We have 2 tendons which form the lateral boundary of the anatomical snuff box, extensor pollicis brevis and abductor pollicis longus. And they are forming the first extensor compartment. We have what's called the extensor compartment, and there are 6 compartments. The first compartment is the abductor pollicis longus, extensor pollicis brevis. They are forming the lateral boundary of the anatomical snuff box. And the medial boundary here is the extensor pollicis longus, which forms the medial boundary of the anatomical snuff box. Then I have the base, our floor of the anatomical snuff box, which is formed of the radial styloid process, scaphoid bone, and the triquetrum. Radial styloid process, scaphoid bone, and the triquetrum. And then the content in the roof is the cephalic vein, and in the floor I have the radial artery, and also I have superficial radial nerve which passes through it. These are the anatomical snuff box boundaries. Very important to know them. It passes between, the radial artery passes between the first and the second extensor compartments. The first is formed of extensor pollicis brevis, abductor pollicis longus, while the second is extensor pollicis longus tendon. This is the first and this is the second. And we will go back through the 6 extensor compartments of the wrist. This is a very important. Then we will go through another topic. This is the anatomical snuff box. Here I have the anatomical snuff box. What's important here? What forms the anatomical snuff box? This is the anatomical snuff box. Triangular depression over the lateral dorsal aspect of the wrist, which is formed by the lateral boundary. They are the contents of the first extensor compartment, extensor pollicis brevis, abductor pollicis longus. This is the lateral, while the medial is the extensor pollicis longus. Here is the extensor pollicis longus. And the content here, which passes in the roof, is the cephalic vein, passes in the roof, and we have the radial artery. Okay, and as I said, the floor is the radial styloid process, scaphoid, and triquetrum. Okay, then this is the anatomical snuff box, which is a triangular depression on the posterolateral part of the wrist. We have found in the base of the wrist. The lateral boundary is formed of the first extensor compartment, which is the abductor pollicis longus, extensor pollicis brevis, the medial boundary with extensor pollicis longus, while the floor is formed of the radial styloid process, scaphoid, and trapezium. Okay, what are the contents? Contents, there are 3: cephalic vein, radial nerve, radial artery. Cephalic vein, radial nerve, radial artery. Please keep this. We have here what's called carpal tunnel syndrome. This is entrapment of the median nerve below the flexor retinaculum. The patient will present by manifestation of median nerve compression. What are the manifestations of median nerve compression? The patient in the initial will start by tingling, numbness, pain, over the distribution of the median nerve. We have here, this is the thumb, index, middle, and little. Okay. This here, lateral 3.5 fingers, thenar muscles. This is the distribution of the median nerve, which supplies sensation to the palmar aspect of the lateral 2/3 of palm and lateral 3.5 fingers, skin over the thenar muscles, and also give motor to what's called loaf muscle. Loaf muscle is the lateral two lumbricals. OEF are the thenar muscles. Opponents pollicis, abductor pollicis brevis, flexor pollicis brevis. This is the innervation of the median nerve. What's important also to know, we have two tests to know the carpal tunnel syndrome. They are called the Tinel test. Tinel test is direct tapping over the wrist. The patient will have tingling numbness over the median nerve distribution. And also I have another test which is called the Fallon test, where the patient can flex his hand for about 15 to 60 seconds. Then the patient will have tingling and numbness also over the distribution of median nerve. What are the causes of carpal tunnel syndrome? We have a lot of causes like obesity, rheumatoid arthritis, space occupying lesion either appears like any mass in the bone, any mass in the synovial sheath, even ganglion, even patient has amyloidosis or acromegaly, a lot of causes of carpal tunnel syndrome. In mild or moderate cases, we go for splinting of the joint and supportive management like painkillers. But in severe cases with severe pain, we will go for carpal tunnel release. Okay, carpal tunnel release. This is carpal tunnel syndrome. We'll discuss another condition. What's called decurvian syndrome or decurvian tenovaginitis. What is decurvian syndrome or decurvian tenovaginitis? Inflammatory process of the first dorsal extensor compartment. First dorsal extensor compartment is the lateral boundary of the anatomical snuff box. I said before. Extensor pollicis brevis, abductor pollicis longus. Extensor pollicis brevis, abductor pollicis longus. You will see pain here on flexion or extension and complete abduction of the thumb. This is called Frankenstein test. Frankenstein test. Please keep this. Frankenstein test is a diagnostic test of decurvian tenovaginitis. This is an important syndrome which came in previous exams. Decurvian tenovaginitis is an inflammatory process of the first dorsal extensor compartment. Extensor pollicis brevis, abductor pollicis longus. Pain appears on flexion and extension and abduction of the thumb. The diagnostic test is called Frankenstein sign or Frankenstein test. Okay, this is decurvian. We will discuss trigger finger. Here we have what's called trigger finger. Trigger finger is a syndrome which typically appears when the patient try to flex his finger due to locking of the flexor tendon. The patient, when try to flex his finger, he will catch or snap sound appears on flexing the flexor tendon. This is a very important condition causing severe dysfunction and pain and related to fibrosis and tightening of the flexor tendon. This is what's called a trigger finger. Please keep this. Now we will go to discuss the most important topic in the upper limb, which is the brachial plexus. Brachial plexus, we have here. This is the brachial plexus, which started from anterior primary rami of C5, 6, 7, 8, and T1. Then They are what's called roots. Then roots unite together to form the trunks. C5 and C6 will form the superior trunk. C7 continue alone to form the middle trunk, while C8 and T1 form the inferior trunk. Please keep this. No branches from any trunk except the superior trunk, which give you 2 branches. I will say them later. Then we'll continue roots, trunks, and I have divisions. Each trunk is divided into anterior and posterior division. Anterior and posterior division. The posterior of the 3 will form the posterior cord, while the anterior of the upper and middle trunk will form the lateral cord, while the anterior of the inferior trunk will form the medial cord. Please focus. Then again, roots of the brachial plexus, anterior primary rami from C5 to T1. Branches from the roots are 3. Branches from the upper trunk are 2. Then each one will form superior, middle, and inferior. Superior trunk is formed by C5 and C6. Middle trunk is formed by C7, while inferior from C8 and T1. Then each trunk is divided into anterior and posterior. The posterior of the 3 trunks will form the posterior cord, while anterior of superior and middle trunk will form the lateral cord, and the anterior of the inferior trunk will form the medial cord. Then after cords, we have the branches. We have the terminal branches. Then let's go down to see the most important branches. All branches of the brachial plexus, you should keep them all. All branches of the brachial plexus, you should keep them. Then let's start. We have branches from roots. I said roots from C5 to T1. Branches from roots, there are 3 branches. We have from C5 contribution to phrenic nerve. Phrenic nerve, which is supplying the diaphragm, is formed of C4, 5, C3, 4, and 5. C5 is part of the brachial plexus. So the first branch from the roots is contribution to phrenic nerve. Then another one, which is called dorsal scapular nerve. Dorsal scapular nerve or nerve to rhomboids. Please keep this, nerve to rhomboids. This nerve supplying the rhomboid major and minor and give a contribution to levator scapulae muscle. This is the dorsal scapular nerve. Another very important nerve which arising from C5, 6, and 7 and goes downward is the long thoracic nerve of Bell, which is the nerve to serratus anterior. This is a very important nerve. Then keep this with me. We have 3 branches from root, C5 to phrenic nerve and dorsal scapular nerve, which give innervation to rhomboids major and minor and levator scapulae, and long thoracic nerve, which is the nerve to serratus anterior. C5, 6, and 7. These are the branches of the roots. Then we have 2 branches from the upper trunk. The first branch is suprascapular nerve, and nerve to subclavius. To keep this, they are arising from the upper trunk. So their root value will be C5 and 6 because they are from the superior trunk of the brachial plexus. Suprascapular nerve, C5 and 6, will supply supraspinatus and infraspinatus muscles. They are the rotator cuff muscles. I said before, they form the word sets. Supraspinatus, infraspinatus, teres minor, and subscapularis. So suprascapular nerve supplying supraspinatus and infraspinatus. And nerve to subclavius, which is supplying subclavius muscle. Root value C5 and 6. Then they are the branches of the upper trunk. Other trunks have no branches. After trunks, we have divisions into anterior and posterior. We will start by lateral cord. Lateral cord, which is formed of anterior division of superior and middle trunk. These are the branches of the lateral cord. We have what's important here is lateral pectoral nerve. Lateral pectoral nerve is an important nerve which pairs what's called clavipectoral fascia. What is the clavipectoral fascia? It's the fascia enclosing, here is the clavicle, and here is the subclavius muscle. It starts from the clavicle, include the subclavius muscle, forms a boundary downward, then pectoralis minor, then it forms the suspensory ligament of the axilla. Okay, please focus with me. We have the clavicle, subclavius muscle, clavipectoral fascia, pectoralis minor, and suspensory ligament of the axilla. These five will form the anterior boundary of the axilla. Please focus with me, okay? Then, the lateral pectoral nerve, which is supplying the pectoralis major muscle. This is the first branch of the lateral cord. And also we have what's called the musculocutaneous nerve. And this is a very important nerve. Musculocutaneous nerve is supplying the PPC muscles. What are the PPC muscles? They are the biceps, brachialis, coracobrachialis. These are the PPC muscles, musculocutaneous nerve. The musculocutaneous nerve supplying the biceps, brachialis, and coracobrachialis, and continue as the lateral cutaneous nerve of forearm, which is supplying the lateral part of the forearm here. Okay, these are the branches of the lateral cord. Please keep this with me. We have a lateral pectoral nerve, which pairs the clavipectoral fascia. And I have the musculocutaneous nerve, which is supplying the PPC muscle, biceps, brachialis, coracobrachialis. And also I have the lateral branch of the median nerve. Lateral branch of median nerve. Please keep this as the lateral branch of median nerve is giving a contribution to the ulnar nerve here. Also with C7 can give a contribution to the ulnar nerve, because ulnar nerve takes two contributions, one from the lateral part or lateral root of median nerve and one from C7. These are the three branches of the lateral cord: lateral pectoral nerve, musculocutaneous nerve, and the lateral root of median nerve. Then I'll go to the most simple medial cord. The medial cord, which forms here, we have the medial cord, which is started by medial pectoral nerve. We have medial pectoral nerve here, which is supplying M with M. Medial pectoral nerve to supply the pectoralis minor. Medial pectoral nerve supplying the pectoralis minor. And also give a contribution to pectoralis major. So pectoralis major has a double blood supply from lateral pectoral nerve and medial pectoral nerve. But the main supply, nerve supply for pectoralis minor is medial, M with M. Pectoralis minor with median pectoral nerve. Then I have the medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and the two terminal branches here is ulnar nerve, the most important here, and the median branch of the median nerve. Please keep this. We have five. All medial branches are M, medial. We have medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and the most median nerve is ulnar nerve and the medial root of median nerve. All medial branches of the medial cord. Please keep this. Then we will continue to the posterior cord. Posterior cord forms the word ulnar. Here is the posterior cord, which is formed by the posterior branches of the trunks, posterior divisions of trunks. Okay, it forms the word ulnar. I will go above. Here, the posterior, three posterior divisions of the trunks. Two forms of what's called, I collected them in the word ulnar. But the main ulnar is from the medial cord, not from the posterior cord. But the posterior cord is collected in the word ulnar. We have U for upper subscapular nerve, upper subscapular nerve. Okay, then L for lower subscapular nerve. Then N is nerve 2 latissimus dorsi, thoracodorsal nerve. Then the two terminal branches, which are axillary and radial. Please keep this. They are collected in the word ulnar, upper subscapular, lower subscapular, nerve 2 latissimus dorsi, and axillary nerve, radial nerve. But the mean ulnar is from the medial cord, while the posterior cord formed the word ulnar. Keep this, please. Brachial plexus is very important. Okay, then now I will go regarding sites. Sites of the brachial plexus are very important. Here, you should know where are the roots of the brachial plexus, which are found related to the cervical vertebrae, transverse foramina of the cervical vertebrae from C5 till T1. These are the roots. But trunks which are associated with thoracic outlet syndrome. Most important to remember, trunks are found in the posterior triangle, posterior to subclavian artery, between the anterior and middle scalene muscles. Here we have a syndrome which is called thoracic outlet syndrome due to tight scalene muscle or subclavian aneurysm, okay, or even cervical rib, causing compression of the trunks of the brachial plexus in the posterior triangle. Please keep this. And here we have the divisions. Divisions are found behind the middle 1/3 of the clavicle, and cords which are related to the second part axillary artery. They are related to the second part axillary artery. Medial cord is medial to the second part. Lateral cord is lateral to the second part axillary artery, while posterior cord is posterior to it. This is a very important. Here, the median nerve. The most important to know about median nerve, which starts from the posterior cord, median nerve, okay. And we have also union of medial and lateral roots from medial and lateral cords, okay. Excuse me, it's from medial and lateral cord of the brachial plexus. Then we have two roots which passes anterior to the axillary artery, then passes downwards. Please keep this relation. We have the brachial artery and the median nerve. This relation, because the median nerve here started laterally at the middle of the forearm, it became anterior. Then in the lower forearm, it became medial. So relation of median nerve to brachial artery forming the word lamb. Lateral, then at the middle of the arm, middle 1/3, it became anterior. Then on the lower arm, it became on the medial side, to pass in the medial side of the cubital fossa. Please remember this. Relation of median nerve to brachial artery forms the word slam. Above, it is lateral. In the middle 1/3, it is anterior. In the lower 1/3, it is medial, to pass as the most medial structure in the cubital fossa. Then it enters the forearm between the two heads of pronator tears. Each nerve passes through muscle to reach the forearm. Keep this. Median nerve passes between the two heads of pronator teres to reach the forearm. Ulnar nerve passes between the two heads of flexor carpi ulnaris to reach the forearm. Radial nerve passes between brachialis and brachioradialis to reach the forearm. Please keep this. This is the entry of each nerve towards the forearm. Again, median nerve between two hits of pronator teres, ulnar nerve between two hits of flexor carpi ulnaris, radial nerve between brachialis and brachioradialis muscle. What is the supply of median nerve? I said before, the supply of median nerve, sensory and motor. We have motor, which forms the word loaf muscle. Loaf muscle in the hand, they are the lateral two lumbricals and the thenar muscle. Opponents pollicis, abductor pollicis brevis, and flexor pollicis brevis. And it supplies the lateral 2/3 of the ball, sensory, cutaneous sensation, and lateral 3.5 fingers. Then here, I am going to discuss a very important condition, what's called herpes palsy and Columbus palsy. Please focus with me. What's the difference between herpes palsy and the Columbus palsy? Herpes palsy is an injury to the upper trunk, upper R with herpes, while Columbus palsy, L, injury to lower. So R with R, L with L. Herpes palsy is injury to the upper trunk. Here, what are the nerves arising from above? You should know from above, we have musculocutaneous nerve, the most important to be injured, and suprascapular nerve. They are from the trunk and lateral cords. Musculocutaneous nerve and suprascapular nerve. Musculocutaneous nerve is supplying which muscles? BBC, biceps, brachialis, coracobrachialis. Suprascapular nerve is supplying the supraspinatus and infraspinatus. So, what will be lost in this patient with herpes palsy when there is injury to the upper trunk? Musculocutaneous nerve, injury to biceps. Biceps causing flexion of the elbow. So, there will be extension of elbow. Biceps is a very important supinator of the forearm. So, there will be pronation of the forearm. So, extension and the pronation of the forearm. When there is injury to the suprascapular nerve, so there is supraspinatus and the infraspinatus muscles will be injured. Supraspinatus, which is responsible for initiation of abduction. So, the arm will be adducted. While infraspinatus is one of the lateral rotators of the shoulder. So, the shoulder will be medially rotated. So, the most important movements of this will be the position of the patient where the forearm is extended and pronated, but the arm is adducted and internally or medially rotated. This is called a Witter tip or policeman deformity. Again, this is herpes palsy, injury to the upper trunk. We have injury here to the most important two nerves, musculocutaneous and suprascapular nerve. Musculocutaneous supplying biceps, brachialis, coracobrachialis, while suprascapular nerve supplying the supraspinatus and the infraspinatus. Injury to biceps, loss of flexion and supination. So there is an extension and the pronation of the forearm. Injury to supraspinatus and infraspinatus, loss of abduction and the lateral rotation. So arm will be adducted and internally rotated. This is a policeman or Witter tip deformity. Regarding motor, so what will be the sensory loss? We have C5 and C6. These are the roots of the upper trunk. So here is the arm, thumb, and this is the hand. Okay, till the level of the forearm. We have here, this is the C5, supplying that, then till the middle of the forearm is the C6, then here is the C7. So what will be the loss? There will be loss on the radial aspect of the arm and the forearm, on the lateral aspect of the arm and the forearm. This is the cutaneous loss. So to remember it, herpes, we have herpes. I will erase that. we have Erb's palsy in the upper trunk, in the radial side of the arm and the forearm, which are lost, and the patient has a waiter tip deformity or policeman tip deformity, whereas the arm is adducted, internally rotated, and the elbow is extended and pronated. This is the Erb's palsy. Let's go to Klombeck's palsy, where the patient has injury to the lower trunk. Lower trunk is C8, T1. C8 and T1. Please keep this. Then, when the patient has injury to the lower trunk, what's the most important nerve to be injured here is the ulnar nerve. This is the ulnar nerve, which is supplying all intrinsic muscles of the hand. All intrinsic muscles of the hand. So there will be paralysis of all intrinsic muscles of the hand, except the loaf muscle, which are supplying by the median nerve. But the medial root of median nerve is arising from the lower trunk. So the median nerve also will be affected. So all loaf muscle will be affected. Here the patient will have, at the hand level, there will be paralysis of all intrinsic muscles of the hand. The patient will have the characteristic deformity, which is called claw hand. Claw hand is a hyper extension of the metacarpopharyngeal joint and flexion of the interpharyngeal joints. This is the Klombeck's palsy, injury to the lower trunk, C8 and T1. Okay, and here is what is the level of the sensory loss, C8 and T1 here, C8 and T1, well, this is hand, thumb, these are the fingers, as I said, this is the forearm, we have here C5, then till the middle of the forearm, C6, then thumb, C7, in the middle of the hand and the other hand is the C8, and in the medial aspect of the forearm is the T1. So we have here C8, T1, where there is on the ulnar aspect, L, lower Klombeck's, lower trunk, and lost sensation over the ulnar aspect of the forearm and hand. Please keep Klombeck's and Erb's palsy. Okay, that's all what you know about Erb's and Klombeck's. Then let's continue. We will have muscles of the shoulder region. To keep muscles of the shoulder region, here is the muscle what's called the trapezius, which arising from here I have the superior nuchal line, and in the middle is called the external occipital protuberance, and ligamentum nuchae, which is found between the transverse process of all cervical vertebrae, then all thoracic vertebrae, okay, then to be inserted into the lateral part of the spine, acromion, and the lateral part of the clavicle. Here is the origin and the insertion of the trapezius muscle. Trapezius muscle from the superior nuchal line, external occipital protuberance, ligamentum nuchae, all cervical vertebrae, and all thoracic vertebrae to be inserted into lateral part of the spine, acromion, and the lateral part of the clavicle. Here is the origin and the insertion of trapezius. We have also the deltoid muscle. Deltoid muscle has an origin which impresses the insertion of trapezius. The trapezius from inside, while the deltoid is from outside, outer border of the lateral part of the spine, acromion also, and the lateral part of the clavicle, to be inserted downward in the deltoid tuberosity in the middle of the lateral part of shaft of the humerus. This is a very important, trapezius and deltoid. What's the nerve supply of trapezius? Trapezius, which has motor and sensory. Motor from spinal accessory. Spinal accessory supplies trapezius and sternocleidomastoid muscle. And sensory proprioception from anterior primary rami of C3 and C4. This is the trapezius. And deltoid is supplied by axillary nerve. What is the other muscle which is supplied by axillary nerve? Please keep this. This is teres minor. This is the other muscle which is supplied by the axillary nerve C5 and C6. Teres minor muscle. Here is the trapezius and deltoid, and the axillary nerve also is supplying the teres minor and the deltoid muscle. Okay. Here you are muscles, rhomboides major and minor, and levator just for reading, not too important. We will discuss the most important, which are the rotator cuff muscles. These are the rotator cuff muscles, which I said before, they form the word sets: supraspinatus, infraspinatus, and teres minor. Here is the supraspinatus, which arising from the supraspinous fossa, infraspinatus from infraspinous fossa, while the teres minor and teres major. I have here the lateral border of the scapula. Where is the scapula here? And I have the lateral border of the scapula. Above is the teres minor and below is the teres major. So the upper 2/3 of the lateral border of the scapula is the minor, and the lower 1/3 is the origin of major. Please keep SIT, supraspinatus, infraspinatus, teres minor, all are inserted into the greater tubercle of the humerus. Please keep this. While the subscapularis in the lesser tubercle, and it is not here. But the most important is teres major. I said before the insertion of teres major. Do you remember major, and between them is the latissimus dorsi. Lateral lip of intertubercular sulcus or bicipital groove is for pectoralis major. Medial lip of intertubercular sulcus is for teres major, while the floor in between is for latissimus dorsi. Okay, the nerve supply for supraspinatus and infraspinatus is the suprascapular nerve. Teres minor, I said, deltoid and the teres minor are by axillary nerve, while the teres major is supplied by lower subscapular nerve. Lower subscapular nerve. And I will discuss the triceps muscle in details after that. Here I have the most important condition, which is called posterior scapular spaces. Posterior scapular spaces. Please keep this. What are the posterior scapular spaces? There are 3 important spaces in the posterior scapular or the posterior axillary region. They are a quadrangular space, and we have 2 triangular spaces. Quadrangular space and 2 triangular. The most important is the quadrangular, and it came in the exams before. Let's zoom it. We have here 2 muscles, teres minor, teres major, and they have a long head of triceps, and the most lateral is the humerus. Here I have drawn them. I have here the quadrangular space. I have here triangular space, and I have here triangular interval. The space is above and the interval is below. So from now we can tell the boundaries of each space. The quadrangular space above is teres minor, below is teres major, lateral is humerus, and the medial is long head of triceps. 2 important structures passing through this quadrangular space: axillary nerve and the posterior circumflex humeral artery. Axillary nerve and posterior circumflex humeral artery. From which is this posterior circumflex humeral? This is from the 3rd part axillary artery. We will discuss axillary artery also. Then I have this triangular space. We can tell the boundary. I have above the teres minor, below teres major, and laterally is the long head of triceps. What is the content of this triangular space above? Is circumflex scapular artery. Circumflex scapular artery is branched from subscapular artery, which arising from 3rd part axillary artery. Circumflex scapular artery is branched from subscapular artery from 3rd part axillary artery. Then I have the triangular interval. This is the interval which is found below the teres major. I have the boundaries above teres major, medial long head of triceps, and lateral is the humerus. The most important structures which passing in this triangular interval is radial nerve and profunda brachii artery. Radial nerve and profunda brachii artery. Please keep this. Radial nerve and profunda brachii artery. Then, now, we will take a rest about 10 minutes. Then we will go back to discuss axilla and breast, and to continue the axillary artery and the brachial artery. Okay? Then we'll take a rest for 10 minutes, then we'll come back. We will continue by the axilla. What's axilla? Axilla is the gateway of the upper limb, which provide an extension from the chest towards the upper limb. It is a pyramidal space which is formed of, we have here initially the apex of the axilla, which is started the clavicle, and here I have the first rib, and the posterior part is the scapula. Clavicle and first rib and the scapula. This is the apex. Apex is a triangular in shape, while the whole axilla is a pyramidal in shape. I have the anterior wall of the axilla, which is formed of, even in female, we have the breast, which over the pectoral fascia and pectoralis major and minor muscles and the clavipectoral fascia. What's important is pectoralis fascia, pectoralis major muscle, pectoralis minor muscle, subclavius, and the clavipectoral fascia. The medial wall is formed of upper four ribs. Upper four ribs is the medial boundary of the axilla, while the lateral part is the intertubercular sulcus of the humerus. What's important here is the posterior wall of the axilla, which is formed by muscles collected in the word SLT, subscapularis, latissimus dorsi, teres major, and the triceps brachii. SLT, subscapularis, latissimus dorsi, teres major, and the triceps brachii muscle. Very important to know, there is a triple relation between teres major and the latissimus dorsi. Triple relation, where I have here the latissimus dorsi muscle, then this is the teres major. At the first, it became posterior, then below, then anterior. Okay, this is the triple relation between latissimus dorsi and the teres major. This is the latissimus dorsi muscle, and this is the teres major. Posterior, inferior, and anterior. Okay, this is a very important to know also. So, muscles of the posterior wall of the axilla are formed in the word SLT. Then, what are the contents of the axilla? We have axillary artery and axillary vein. We have axillary lymphatics and lymph nodes. Added to them, I have also cords of the brachial plexus, which are related to the second part, axillary artery. Added to them, axillary tail of the breast, and a sheath, which is called axillary sheath. Axillary sheath is an extension from the prevertebral fascia around the subclavian vessels downward to the axilla. It is called axillary sheath. So there are 5 structures as a content of the axilla: axillary artery, axillary vein, and lymphatics, and cords of the brachial plexus, and axillary tail of breast with axillary sheath. Okay, here you are, some muscles of the pectoral region, which are the pectoralis major muscle and minor and subclavius. The most important here is the pectoralis major, which has 2 heads. Pectoralis major muscle has 2 heads: clavicular head and sternocostal head. Clavicular head, which is arising from the medial 2/3 of the clavicle, and sternocostal head from upper 6 ribs and costal cartilage. And I said before, the insertion, we have the lateral lip of intertubercular sulcus for pectoralis major, and the medial lip of intertubercular sulcus for teres major, and the floor is for latissimus dorsi. So this is the pectoralis major, and it has double nerve supply, medial and lateral pectoral nerve. What is the action of the pectoralis major? Play an important role in flexion, adduction, internal rotation. I collect the action in the word fam, flexion, adduction, and medial rotation. This is FM. Okay, then subclavius. The most important for subclavius is not origin or essential, but it is the nerve to subclavius, C5 and 6. And then pectoralis minor, which are rising from reps 3, 4, 5 reps to be inserted into coracoid process. And I said M with M. So pectoralis minor is a medial pectoral nerve, and its action is protraction of the scapula. Protraction, which scan forward movement of the scapula. Protraction. Okay. So pectoralis minor from reps 3, 4, 5 to be inserted into coracoid process. M with medial pectoral nerve, and its action is protraction of the scapula. Then we will go muscles of the posterior wall of axilla, which are collected in the word SLT. They are, I said, collected in the word SLT. We have the subscapularis, latissimus dorsi, teres major, and triceps. These are the muscles of the posterior wall of the axilla. Subscapularis from the subscapular fossa to be inserted into the lesser tubercle. This one of the rotator cuff muscles is SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. The only one which can do internal rotation with teres major. They are the two muscles which can do internal rotation or medial rotation. The all three, supraspinatus, infraspinatus, teres minor, causing lateral rotation, while the subscapularis with teres major causing internal rotation. And here is the latissimus dorsi muscle. I will show you a picture for latissimus dorsi muscle to know the origin and the insertion. Like this. Here we have here the latissimus dorsi muscle. Very important to keep it, which is arising from lower 6 thoracic vertebrae, all lumbar, lower 6 thoracic vertebrae, all lumbar, and thoracolumbar fascia. Then also it arises from the iliac crest and lower 3 to 4 ribs. This is the origin of the latissimus dorsi. We have two major muscles on the back, trapezius, which is from above, and latissimus dorsi from below. Latissimus dorsi, which is arising from lower 4 thoracic vertebrae, all lumbar, thoracolumbar fascia, iliac crest, lower 4 ribs to be inserted in. Do you remember the insertion of latissimus dorsi? I said before there is a major, and in between them is the latissimus dorsi. Lateral lip of intertubercular sulcus for pectoralis major, medial lip of intertubercular sulcus for teres major, while the floor of the intertubercular sulcus or bicipital groove is for latissimus dorsi. This is a very important muscle. Please keep it. Okay. Then another one. The muscles which are called supplied by musculocutaneous nerve. They are the BBC muscles. BBC muscles. Biceps, brachialis, coracobrachialis. The three muscles which are supplied by musculocutaneous nerve. Coracobrachialis, here, coraco, so it is from coracoid. Then brachialis, I said, opposite the insertion of the deltoid tuberosity, we have the insertion of the coracobrachialis. I have here the head of the humerus, head, anatomical neck, surgical neck, greater tubercle, lesser tubercle, intertubercle sulcus, and deltoid tuberosity for insertion of the deltoid muscle. Here is the lateral and medial, and the opposite the deltoid tuberosity is the insertion of the coracobrachialis muscle. And the biceps brachii, I said we have two heads, long head from the supraglenoid tubercle of biceps, while the long head of triceps is from infraglenoid tubercle. So long head from the supraglenoid tubercle, while the short head is from the coracoid process. Please keep this, coracoid process. So coracoid process gives two origin and one insertion. Two origin for coracobrachialis and short head of biceps, and one insertion for pectoralis minor muscle. These are three muscles attached to the coracoid process: coracobrachialis, short head of biceps, and pectoralis minor muscle. And there are some ligaments, coracoclavicular and coracoacromial ligaments. These are the muscles and the ligaments attached to the coracoid process. I say it, coracoid process is the most anterior because A is not A. Acromion is posterior while coracoid is anterior. Okay, then this is important. So biceps is inserted into radial tuberosity. Biceps is inserted into radial tuberosity of the radius, while brachialis, which is originate from the lower part of the front of the humerus, to be inserted into ulnar tuberosity. All of them are supplied by musculocutaneous, all of them causing flexion of the forearm. All of them causing flexion of the forearm. So keep the three PPC muscles of the cutaneous nerve. Winging of the scapula, which can occur in any approach reaching the lateral thoracic wall, even through the axilla. During axillary clearance of modified radical mastectomy of the breast, the nerve to serratus anterior or long thoracic nerve of Bell may be injured in this operation. So winging of the scapula is a complication of the axillary clearance of modified radical mastectomy due to injury to long thoracic nerve of Bell or nerve to serratus anterior C5, 6, and 7, causing winging of the scapula. Okay, then this is a most important question asked, which is the rupture of biceps tendon. Rupture of biceps tendon. A very common question to came with the characteristic Popey sign. What's the rupture of biceps tendon? In heavy workers or in gym players, severe trauma to the biceps causing rupture of long head of the biceps brachii. So when the patient causing flexion to his elbow, I can see a lump or a bulge of this muscle on the arm. It is called the Popey sign. Rupture of biceps tendon, long head of biceps tendon, and on flexion of the elbows, there is a prominent bulge causing a Popey sign. This is rupture biceps tendon, a very common question asked. Then here, the serratus anterior muscle, which is digitation from the ribs to be inserted into the scapula, medial border of the scapula. Okay, 8 digitation from the here, I can see it is midway between the costoclavicular and the angle. It arises here from 8 ribs, 8 digitation. Okay, then to be inserted into the scapula, and the nerve supply is the long thoracic nerve of Bell. Function is protraction and prevent winging of the scapula. Okay, it can cause the glenoid cavity to be upwards. Glenoid cavity to be upwards. Another picture. Here we discussed the axilla. We have here the axillary artery. The axillary artery is a continuation of the subclavian artery. Subclavian artery, right subclavian artery arises from brachiocephalic trunk, where the left from the arch of aorta. Okay, then the right from the brachiocephalic subclavian, right subclavian artery from the brachiocephalic to end at the outer border of the first rib. At the outer border of the first rib, it continues as the axillary artery. The axillary artery arises at the outer border of the first rib to end at the lower border of the teres major muscle. And it is divided by muscle which is called pectoralis minor. Pectoralis minor muscle. It divides the axillary artery into 3 parts. The first part is above and medial, proximal. Second part is posterior, Third part is distal and lateral. Okay, here, as you see in the picture, okay, I will get closer. As you see here. Here we have, this is the pectoralis minor, which is arising from third, fourth, fifth ribs to be inserted into coracoid process. And here is the coracoid process, coracobrachialis and short head of biceps. This is the coracoid process. Three muscles are attached to the coracoid process. Here, till the outer border of the first rib, here is the subclavian artery above. Then, at the outer border of the first rib, till the lower border of the teres major. Here is the teres major. This all the axillary artery, which is divided by the pectoralis minor muscle into first, second, and third parts. This are the three parts of the axillary artery. Here we will come to the branches of the axillary artery. The most important here is from each part. First part will give one branch. Second part will give two branches. Third part will give three branches. So the first part will give the superior thoracic. This is from the first part. Then the second part will give the lateral thoracic and acromiothoracic. Acromiothoracic is giving four branches: acromial, deltoid, clavicular, pectoral. Acromial, deltoid, clavicular, pectoral. This is the thoracoacromial trunk, which is arising from second part axillary artery. So the first part will give superior thoracic. Second part will give acromiothoracic, which give axillary, pectoral, deltoid, and clavicular branches. Then lateral thoracic. Then we will go to the third part, which will give three branches. The largest branch of the axillary artery is the subscapular artery. And this is a question came in the exam. Subscapular artery. This is the largest branch of the axillary artery. Here is the subscapular artery. Here's. And it is divided into two branches. Thoracodorsal, which is supplying the latissimus dorsi muscle, and circumflex scapular artery. Circumflex scapular artery, do you remember, which passing through the triangular space? Circumflex scapular artery, which is passing through the triangular space. So the subscapular is giving thoracodorsal and circumflex scapular artery. Then after that, we have anterior and posterior circumflex humeral artery. Anterior and posterior. Do remember, the posterior circumflex humeral artery is passing through the quadrangular space with the axillary nerve. Posterior circumflex humeral artery. Okay, then after the lower part of the teres major, it continues as the brachial artery. The first branch to come from brachial artery is the profunda brachii. Here is the profunda brachii, which is arising from the brachial artery. It passes through the triangular interval with radian nerve. Radian nerve and the profunda brachii artery passing through the triangular interval. So we have branches of axillary artery, and the muscle which is dividing it into three parts is the pectoralis minor. First part will give you superior thoracic. Second part will give you acromiothoracic and lateral thoracic. Third part will give you the largest branch of axillary artery, which is subscapular artery. Subscapular artery is divided into two branches: circumflex scapular and thoracodorsal. Then lateral, another two branches, anterior and posterior circumflex humeral artery. This is very important. Then let's go to lymphatics of the upper limb. Here is the lymphatics of the upper limb. We know that we have 5 groups for axillary lymph nodes. 5 groups. They are forming about 20 to 30 axillary lymph nodes. We have 5 groups. The most important group is the pectoral group. Pectoral group, which is found in the anterior wall of the axilla, and it receives drainage from chest and abdominal wall and breast mammary gland. while the humeral, which is the lateral part from the upper limb. Subscapular, arising with the subscapular vessels, and it can drain the back and shoulder. And these three, humeral, pectoral, subscapular, are draining into central lymph node, then to the apical lymph node. So please keep this. Humeral or lateral from the upper limb, pectoral or anterior from the whole chest and the mammary gland and the upper abdomen. Subscapular from the back and shoulder and the back of neck also. Three, humeral, pectoral, and subscapular, all are draining into central lymph node and then to apical lymph node. Then we have what I said about the brachial artery. I will share a picture for it. This is the brachial artery, where I said that it starts at the lower border of the teres major. I have here, this is the axillary artery, which gives the anterior and posterior circumflex humeral arteries. Then at the lower border of the teres major, it continues as the brachial artery. Brachial artery starts at the lower border of the teres major to end opposite the neck of radius. Neck of radius, this is the end. There is the start and this is the end. Here is the brachial artery. Okay, the brachial artery here gives first branch from it is the profunda brachii. Just below the teres major, it gives the profunda brachii artery, which passes through the triangular interval downward and backward, which can go with the radial nerve surrounding the spiral groove of the humerus. Around the spiral groove of the humerus, through the triangular interval, profunda brachii and radial nerve passes through it. Then brachial artery passes downward on the medial part. Then it gives two collateral branches, superior ulnar collateral and inferior ulnar collateral. So what are the branches of the brachial artery? Initially, brachial artery will give nutrient branches to the bone, muscular branches, and cutaneous branches. They are three branches fixed for every artery: nutrient, muscular, and cutaneous. Then later on, it gives the profunda brachii artery, superior and inferior ulnar collateral, and two terminal branches opposite the neck of radius, which are the radial and ulnar artery. Please keep this. So the profunda brachii is the largest branch of the brachial artery, which passes through the triangular interval and hooks with the radial nerve around the spiral groove backward, and then supplying the whole posterior arm and forearm with the radial nerve. It gives branches which are called radial collateral and posterior descending. Radial collateral and posterior descending. All of this will share in anastomosis around the elbow. Okay, so also to keep branches of profunda brachii artery, it gives affixed branches like nutrient, muscular, and cutaneous branches. Then it will give radial collateral because the brachial artery itself is giving the ulnar collateral. So the profunda will give the radial collateral. Then also give the posterior descending branch, posterior descending, to end by anastomosis with posterior interosseous recurrent from the radial artery. Please keep this for anastomosis around the elbow. These are the branches of the brachial artery and profunda brachii. And here, last slide for today, is the cubital fossa, which is an important structure in the upper limb. What are the boundaries of the cubital fossa? Here is the cubital fossa. Okay, here is the cubital fossa, which is formed by, medially, we have here muscle which is called pronator teres. Okay, and laterally, I have the brachioradialis muscle. So lateral brachioradialis, medial is the pronator teres. And the base of this triangle is an imaginary line from the medial and lateral epicondyles. Okay, from the medial and lateral epicondyle. Here I have the medial part and here's the lateral part. So here is the medial epicondyle, lateral epicondyle, pronator teres, pericuradialis, and the imaginary line between them. These are the boundaries. So what is the floor of this triangle? Two muscles, brachialis muscle and supinator muscle. Brachialis and supinator muscle. So what the most important content of the cubital fossa from medial to lateral? They are forming the word MBBR. The most medial structure is the median nerve. Then I have brachial artery, biceps tendon, and radial nerve. This will appear in this photo. Here, the most medial structure here is the median nerve, then brachial artery, biceps tendon, and radial nerve. MBBR, from medial to lateral. This is the content. And I said floor is the brachialis and supinator. Okay, and the roof. What are the structures passing through the roof? I will tell you. From skin, we have skin and superficial fascia. Superficial fascia containing two veins, the most important two veins. Basilic vein is median and cephalic vein is lateral. Basilic vein is medial and cephalic vein is lateral. The junction between two veins, the very important vein for cannulation during emergency, is a median cubital vein, which passes through the roof of the cubital fossa. So skin, subcutaneous fascia containing end of basilic and cephalic vein with the median cubital vein junctioning between both of them. And also I have anterior branches of medial and lateral cutaneous nerves of the forearm. I have here the medial cutaneous nerve of the forearm and the lateral cutaneous nerve of the forearm. Anterior branches passing here through the roof of the cubital fossa. And the last one and the most important is the bicipital aponeurosis. Bicipital aponeurosis is a condensation of the deep fascia of the roof of the cubital fossa. So what are the boundaries of the cubital fossa? Medially pronator teres, laterally brachioradialis, and the base is an imaginary line between medial and lateral epicondyle. Floor is by brachialis and supinator. Content from medially MBBR, median nerve, brachial artery, biceps tendon, and radial nerve. Then the roof, skin, subcutaneous, containing the end of the cephalic and the basilic. Junctioning between them is the medial cubital vein, anterior branches of medial and lateral cutaneous nerves of the forearm, and the bicipital aponeurosis. Okay, then we have finished our today lecture. For any question, you can send me